Okay, hello everyone. Thank you for joining us today. I am Cassidy Avila with the Center for Optimizing Rural Health, and I'm pleased to welcome you to our monthly webinar. Our presenter today is Mei Kwong with the Center for Connected Health Policy, and she is presenting federal and state telehealth policy updates and trends. And I will introduce her to you in just a moment, but I do want to let you know that we are recording the webinar and we will share a link to the recording as well as a copy of the slides following the presentation today. So you'll receive that in an email within about 24 hours of the presentation completing. I will also be sharing a 60-second survey at the end of the presentation, so please look for that in the chat. And it is now my pleasure to introduce Ms. Kwong. Mei Kwong has over a decade of experience in state and federal policy work. She is currently the Executive Director for the Center for Connected Health Policy, or CCHP, the federally designated National Telehealth Policy Resource Center. She has written numerous policy briefs, crafted state legislation, and led several coalition efforts on a variety of issues. Ms. Kwong has published several articles on telehealth and telehealth policy in various peer-reviewed journals, and is the co-author of CCHP's 50 State Medicaid Telehealth Reimbursement Survey. She is recognized as an expert on telehealth policy and has been consulted by state and federal lawmakers on telehealth legislation and policy. Welcome, Mei, and we're so pleased to have you. And if you give me a moment, I will get your slides up.
Thank you, Cassidy, and thank you for having me here today. I recognize a couple of names from the attendees here, so good to see all of you. I think, Cassidy, I have the full hour, right?
You do.
Okay.
You might leave a couple of minutes at the end for a question or two, but yes, it's all yours.
Okay, great. So I will not be rushing through my presentation, but there'll still be plenty of time for Q&A. So, feel free to put them in the chat as you think of them, and we can always go look at that. And then at the Q&A session, also just like call on folks who feel like they want to ask a question directly and orally. All right, then. So go ahead. As Cassie said, my name is Mei Kwong. I'm the Executive Director at the Center for Connected Health Policy. We're based in Sacramento, California. So let's go to the next slide. Before I start off every talk, I always start off with disclaimers, mainly because I get federal and grant funding, so they want me to start off with disclaimers. So any information that I provide in today's talk should not be considered legal advice. It is strictly for informational purposes. CCHP always recommends that you consult with legal counsel if you want to form a legal opinion. Also, if I happen to mention a company or show a picture of a product or mention a product, know that neither I nor CCHP has any relevant financial interest, arrangement, or relationship with such a company. Next slide, please. A bit of background about CCHP. We were actually established as a California telehealth policy organization in 2009 as a program underneath the Public Health Institute. An opportunity to become the federally designated National Telehealth Policy Resource Center through a grant from HRSA became available in 2012. CCHP applied for that and we got it, and we've been serving in that capacity ever since. And as somebody reminded me earlier, it means our 10-year anniversary is serving as the National Telehealth Policy Resource Center is coming up. It's coming up in September. We also work with a variety of other funders and partners on the state and federal level. So basically what we do is, especially underneath our federal grant, is we provide technical assistance to those who have questions around telehealth policy. Originally, we were set up to actually act as a resource for the other telehealth resource centers underneath the same program as CCHP. There are 12 regional resource centers, and we were supposed to really answer their policy questions when they got them, and they couldn't answer them themselves. However, when we got the grant, the sort of parameters of the work were a little bit vague. So CCHP kind of really shaped and built that over the years on what it would look like. So right now we actually serve as a resource to kind of basically anyone who asks us a question around telehealth policy. So we've helped everybody from the White House and congressional members and state legislators to health systems, to health plans, health providers from either, big medical groups to like a solo practitioner just trying to figure out what telehealth is and how to incorporate it in their practice. And then when COVID-19 hit, we also started helping consumers, like directly patients who were wondering what telehealth is, and we're reaching out just to anybody who seemed to know or have an answer for that. We also have helped a lot of national groups or worked with a lot of national groups as well. So we sometimes work with them on specific projects. So we worked with the Association of State and Territorial Health Offices, the Association of Maternal and Child Health Care Programs. So some of you may have been involved in those projects as well too. We may have crossed paths that way. We are also, CCHP is the administrator for the National Consortium of Telehealth Resource Centers. And what that is made up of the telehealth resource centers who are underneath the same program as CCHP with HRSA. We decided a couple of years ago that we really wanted to work more closely with each other because we found that there was some work that was overlapping. In order to utilize our resources and our funding more efficiently, we decided to collaborate very closely on these common projects or these types of resources that stretch over multiple regions. So each telehealth resource center, the regional ones, they cover specific states, but sometimes there are things that could have applicability in like more than just their territorial states, their regions, and can be useful in multiple regions or useful nationally. CCHP is also the convener for a group in California called the California Telehealth Policy Coalition. So that's made up of, right now we're close to 200 different statewide and national organizations that are interested in advancing telehealth policy in the state of California. Next slide. So I've been asked to talk to you about telehealth policy changes that are going on now. Where are we now on the telehealth policy landscape, both on the federal and the state level? And this slide here, and I apologize for the overlapping, I think when you get the PDF, it'll be a little bit clearer. But basically, this is kind of your 50,000 level foot overview of like what happened during COVID-19 around telehealth policy, what changes were made both on this federal and the state level. And I broke it out into sort of issue areas or policy areas where the change was made and like just exactly what were they allowing, just like a couple of words on there. And you'll notice that there's a lot of commonalities, at least on the issue areas that were touched upon, that you see both on the federal and state level. And that's mainly because a lot of the existing telehealth specific policy, both on the federal and state level, touch upon the same issue. The biggest issue being around reimbursement, like what is covered and what is paid. Other issues that impact telehealth, of course, are very important, such as prescribing, licensure, malpractice, privacy. But there are very distinct sort of jurisdictions for those. So for example, for prescribing, when you're talking about controlled substance, that's very much in like the federal jurisdiction of like what they say goes, or like to regulate that. Whereas where you're talking about prescribing of basically every other medication besides controlled substance, that's like in the state's sort of jurisdiction to do that. Similar to licensure, licensure is in the purview of the states, not on the federal level, on like how they deal with it. But you do see some commonalities of issue areas, again, and really around that reimbursement side, such as where it can take place, what services are covered, who can get reimbursed for providing that service via telehealth. Next slide. So I split it up between federal and state policy, and you're going to see the federal policy has a lot more content in it, and that's mainly because it's a singular policy. The states, if you include DC, it's 51 jurisdictions. They're all over the place on where they are. So I'm just going to give a high level overview on that. If you want more specifics, I suggest that you go to CCHP's website. We do track things individually for each state, and you can access that through our 50 state map. You click on a particular state and it'll bring up the information, but I'll give like sort of an landscape overview of some commonalities that we're seeing through the states. But we're going to focus mainly on the federal, just because again, it's singular policy. And there's also been a lot of stuff going on there, and the federal policy sometimes has an impact on what goes on the state level as well too, because you have that trickle down effect of like what the feds decide, and sometimes it's replicated on the state, or it impacts the decisions made by the state governments. Next slide. So on the federal level, your telehealth specific policy, the sort of biggest area where that's concentrated is Medicare. Yes, there are other federal policies that impact telehealth or specific to telehealth. I mentioned prescribing earlier, but we're going to focus mainly on Medicare policy because that's sort of the largest area of where there is existing telehealth specific policy. And to understand Medicare policy and how it works with telehealth, you also have to understand that what Medicare does is they have two separate channels for dealing with services that are provided via technology and what they're going to do with that, what they're going to reimburse and cover. And they have one channel or bucket that's called telehealth, and they have another one that's called communications technology-based services. So what's the difference? So telehealth is specifically labeled telehealth delivered services, and this is mainly controlled by what's in federal statute. So these are the policies that most of you are probably familiar with that says, oh, it needs to take place in a rural area, and there's a specific definition of what that means. It needs to take place in these specific types of locations, like a hospital or physician's office, sometimes very narrow services in the home. And it has to be delivered through these types of modalities. These are policies, again, a lot of them are embedded in federal law that say specifically they are telehealth delivered services. There is another channel that Medicare has called communications technology-based services. They still utilize telehealth technology to deliver those services, but they're labeled as something else. They're called communications technology-based services. So what's the difference? Well, for one thing, the communications technology-based services, the parameters of these policies are not embedded in federal law. This has been really CMS created. So it's administratively created their policies. And the way that the CMS distinguishes two is sort of roughly the telehealth policies, the telehealth services, those telehealth services actually replace something that can happen, that typically happens in person. So an office consultation, I go in and see my primary care provider in person. I can do that via telehealth. There's a one-on-one replacement for something that occurs in person. Communications technology services are services that typically don't happen in person, but because technology has advanced to this point, it can now happen. So it's something like, oh, in the past, Medicare couldn't imagine this happening because it wasn't something that would happen in person, but now we can use technology and we can do this, and we think this service will be beneficial to patients. We're going to cover it. So think, for example, I am a patient with high blood pressure. I am not typically going into my clinician's office 3 times a day for 5 days to get a blood pressure reading. However, through communications technology-based services, I can have a blood pressure cuff monitor at home that electronically transmits that information 3 times a day for a period of 5 days to my clinician. So it's a different type of service that you can now do through technology that typically won't see being done in person or wasn't covered in person or imagined in person. So in your communications technology-based services, you have all those things like remote patient monitoring or other services like what they call virtual check-ins, which are quick check-ins with your clinician, like 5 or 10 minutes just to, see how you're doing and everything, and that will be covered. So that's kind of your catch-all, a bit of a catch-all bucket for technology delivered services that don't necessarily replace an in-person service. Now, I'm spending so much time on this is because when the pandemic first started, I think the two got very mixed in together, and people thought that, oh, all these communication-based services are telehealth. Well, technically they are. They utilize technology to provide services from a distance, and that is telehealth. However, Medicare has them separated into very distinct categories. So they're treated differently. So communications technology-based services don't face all of those limitations that telehealth might face, like such as it needs to take place in a rural area. It only is provided by, these providers, or it can only be provided in these types of location settings. They have their other limitations. So CMS has put limitations around these services, but I'm just saying that they don't necessarily have the same limitations as telehealth. And also, since this was administratively created, CMS has much more freedom to set the policies for these without waiting for Congress. For the telehealth policy, since a lot of that is embedded in federal law, they have to wait for Congress to make some changes before CMS can. However, CMS has gotten a little bit creative, and I'll get into that in a second, but this is like the two distinction. These are two separate buckets, two separate ways, two separate policies of how Medicare treats telehealth delivered services or technology delivered services. One is limited and restricted a lot because of what's in federal law. The other one, CMS has a little bit more administrative say over and a little bit more flexibility of doing things without having to wait for Congress. Next slide. So on the federal law side of things, on the telehealth policy side of things, there were a lot of changes that were made temporarily in response to COVID. Now, to understand those policies is to understand telehealth reimbursement policy. And telehealth reimbursement policy roughly can be divided up into four sort of elements or four sort of factors where the policy touches on one or more of these elements. So those are service location, provider, and modality. So for example, you'll see a lot of telehealth reimbursement policy, whether you're talking about Medicare, Medicaid, or a commercial plan, that will say something about one of these issues, or usually more than one of these issues. So for example, you might have a Medicaid policy that says this Medicaid program will cover psychiatric services delivered via telehealth. So that's the services that they'll reimburse for. When the patient is located in a doctor's office or a clinic, the location of the patient, when it's being delivered via live video, the modality, and when it's being delivered by a psychiatrist, the provider who's eligible to deliver those services. So you'll see a lot of the policies really stating something about one of these four elements here. And that's regardless if you're talking about Medicare, Medicaid, or commercial payers. And when COVID-19 hit, federal policy, at least for Medicare, really focused in and touched upon each of these things, like allowed some more waivers or relaxations to expand the limitations on each of these elements. And again, a lot of it was because some of it was embedded in federal law. For example, the location, it's in federal law that says for the Medicare program, the patient needs to be located in a rural or non-metropolitan statistical area, and that needed to be waived in response to COVID. Now, the question then is that what's going to stick around after COVID? What changes have been made that we know will stick around once the public health emergency is declared over? And we'll start getting into that over the next couple of slides. Next slide, please. So I mentioned that there are two ways to change federal policy in Medicare around telehealth. And one way is through legislation, that's Act of Congress, where they change federal law. The other way is administrative changes. So these are changes that CMS institutes. And one of the big ways they do that is through the physician fee schedule. Very quickly, for those who are not familiar with the physician fee schedule, it is basically their policies that they put out to impact the Medicare program for the following year. So for example, for the 22 policies, the policies we have right now, CMS put out regulations, proposed regulations in the summer of 2021. They have a comment period of about 60 days, I think it is. They get those comments back, they assess them, they maybe make some changes in response to those comments, and then they publish like a finalized set of policies or regulations towards the end of the year. So it was in, I believe, like November or maybe early December when they did it for 2022. So that's kind of like roughly how their process of doing this. And that's where they usually include like a lot of administrative changes to telehealth policies in that physician fee schedule. What they did for 2021 and they have now implemented for 2022, we'll go to the next slide, were a couple of major things. Now, keep in mind, though, that these are permanent changes for telehealth policy underneath the Medicare program. However, since we're still in the public health emergency, they have not been activated yet because of the PHE. But the changes that they made really centered around mental health services and using telehealth to deliver them. What will be like a permanent policy once the public health emergency is declared over? And their changes were really a mix of administrative changes that CMS decided to do, but also changes that they were forced to do because of federal legislation that was passed in 2020. And that was the Consolidated Appropriation Act, which was passed in December of 2020. So CMS had to like incorporate those policies as well. So some of the policies that they incorporated, they didn't really have a choice on because of the Consolidated Appropriation Act, because it's now federal law and they had to do it. But other things that they did do on their own. It was their decision to do it. Congress and federal law was not telling them to do it. So there was a mix of like, legislative and administrative action here. And basically, as I said, it's centered around mental health services and providing them via telehealth and how and when you could provide them. So what they did was, in response to Consolidated Appropriation Act, which said that you can provide services, mental health services in the home and without the geographic limitation applying if certain conditions were met. So they incorporated that policy, but they also did administratively open it up to allow audio only to be provided via telehealth. And also they looked at using redefining the mental health visit for FQHCs and RHCs in order for them to use technology to provide services. So let's go to the next slide. I believe it gets into a little bit more detail here. Actually didn't. So basically what they did was there were certain requirements in order to provide services via telehealth if you're talking about mental health. So what it basically required, whether you're talking about audio only or trying to avoid the geographic limitation or allowing it to happen at home, was that you needed to have an in-person visit with the patient. The telehealth provider needed to have an in-person visit with the patient before the services could be provided via telehealth, which is something that was embedded in federal law that was underneath the Consolidated Appropriation Act. So CMS didn't have a choice in that. However, they also made that requirement that if you were going to provide services, mental health services, via audio only as well. So they did make that choice to replicate that policy for audio only that was imposed by law for mental health visit. I know this gets a little bit confusing. It's sort of like you need a kind of a graph to do this, but basically Consolidated Appropriation Act said you can provide mental health services in the home and without the geographical limitation happening if the telehealth provider had an in-person visit where you actually had a service that was reimbursed by Medicare take place at least 6 months prior before those telehealth services are given to the patient. And then Medicare added something administratively and said, like, you can provide mental health visits with audio only, but they also replicated that requirement of having that in-person visit as well too. Now, they also added a couple of other requirements, definitely for that audio only, that such as that the provider needed to have like live video available as an option, and that also it was like patient choice that they wanted audio only, or they couldn't do video. So there were like a couple other requirements on there as well too. And your question may be saying like, well, the law only required the mental health visit to take place in person or in the home and without the geographic limitation. How did CMS do the audio only policy without that sort of statutory change being done by Congress? And as I said, that was an administrative change, and they did it by redefining what it meant to be a telecommunication system. So underneath the telehealth policy in statute, it says basically telehealth services are delivered via telecommunication system. It never defined what that is in federal law. That's always been an administrative or CMS thing where they define what that meant. So basically, and for them to allow audio only to happen for mental health visits, they simply just redefine what a telecommunication system meant, and they included audio only for mental health visits. So that's how they were able to make that change. But then because it was administrative change, they added all these other conditions on there in order for that to happen, and they can do that administratively. Very similar to the FQHC and RHC and allowing them to provide services for via technology for mental health and get reimbursed for that. How are they able to do that? Because as some of you may be familiar, FQHCs and RHCs, if we're not in a public health emergency, are not eligible telehealth providers, and that would require a statutory change for that to be allowed to happen outside of a public health emergency. What CMS did was, again, taking that tact of redefining things. They redefined what a mental health visit meant for an FQHC and RHC to include the use of live video and audio only to deliver that services. What that means then is that FQHCs and RHCs are not telehealth providers. They are simply providing a mental health visit, what it means for them. They've just expanded what that means, that definition of that mental health visit, to allow the use of live video and audio only. So that means that FQHCs and
Yours mine's better.
RHCs will still get their PPS or air rate, the regular reimbursement for those services, but they're not considered as providing telehealth. They're just simply providing a mental health visit. Again, it's very confusing. It's very detailed. So my apologies if you're still confused by that. During the Q&A, we can try to clear that up more if you're still confused. But it's like these different levels of policies and approaches on it, simply because I think CMS was trying to work as much as they can within their powers, without, not having something done in Congress first to allow them to like try to expand things. Other things underneath the public or the physician fee schedule was things that they can do is also add the list of services that would be eligible to be reimbursed if provided via telehealth. This is one thing actually where CMS does have control. So they don't have to wait around for Congress for this. They can decide like, these are the services we're going to cover in Medicare if they're provided via telehealth. And the way they do that though is pretty limited in what they decide, because they have a test that they do. So they have two ways for services to get onto the permanent list of what will be reimbursed. And they are called a category 1 test and category 2 test. The category 1 test is, well, if this service that you're suggesting be put on the permanent list, is it similar to a service that's already on the permanent list? And that's usually how like a lot of things get on the permanent list. Then the category 2 test is, well, a lot of evidence is provided to show us that this service can be provided via telehealth, and it'll be effective in like using telehealth to provide the service and the patient would benefit. That's a little bit harder to pass that test, just simply because it's a little bit vaguer. You're not quite sure, well, how much evidence do you need to submit, what type of evidence, etc. What CMS has also done is they created a category 3, which isn't necessarily a test, but a holding bucket for services. So as some of you may be familiar, when the public health emergency hit, CMS expanded the list temporarily of what services can be provided via telehealth that they would reimburse for. Now, this was a temporary list. They added like, I think about 150 additional codes that would be reimbursed if telehealth was used to provide them. However, that is a temporary list. So once the public health emergency is over, theoretically, those codes on that temporary list that are not permanent code on the permanent telehealth list will go away. But what CMS did was there were a handful that they did move over to the permanent list, and they did that in 2021. But then there were about 50 or 60 codes that they put into what they called category 3. And as I said, this is a temporary holding bucket. So what category 3 is that if these codes were put into a category 3 bucket, they will stick around until the end of 2023. So if the public health emergency is declared over December 2022, these codes in category 3 will at least stick around for an additional year. But all those temporary codes that were not made permanent or were not in category 3 that are on the temporary COVID telehealth list will automatically end or cease to be reimbursed once the public health emergency is declared over. So that's what category 3 is. And that's like a temporary holding pen for some of the codes that were allowed during COVID-19. Next slide. So we're now getting into that other channel that CMS has or Medicare has for technology delivered services, and that's that communications technology based services. So the CTBS, or is the acronym for it, is basically services that you can provide via telehealth. It does include live video and some live video and store and forward services, but it's really where you also find your remote patient monitoring services, and they give them different names. They call them like, chronic care management, or they were called them remote physiological monitoring. And then they created a new category for 22 called remote therapeutic monitoring. I'm not going to go over each of these like definitions, but again, just wanted to tell you this was a new sort of category in that remote monitoring bucket that they created a set of codes for, and exactly you can see the definitions for each of them. So next slide. So these were a couple other changes that they've made. Again, in the CTPS area, they made permanent adoption of G2252. So this is virtual check-in. I mentioned it earlier. Virtual check-ins consider a quick check-in, 5 or 10 minutes. They had created a code during the pandemic where it was a quicker virtual check-in where it will last 11 to 20 minutes. So they made that something permanent going forward. They also added a couple other codes or finalized codes in some of those other remote patient monitoring subcategories, such as principal care management and chronic care management. Next slide. These are a couple other sort of changes that they made to policy that impacts telehealth that was in there. Certain things such as what the new reimbursement amount would be for the originating site facility fee. So again, I'm not going to go over these, but these are like other policy changes that they make administratively that do impact the use of telehealth and providers who use telehealth. Next slide. A couple other federal things out there to be aware of. So the OIG, Office of the Inspector General, has been really looking at telehealth and the whole question around the F word, fraud, and misuse and abuse of funds. And to this point, they have not found anything specific to telehealth. They have found cases where there's been maybe telemarketing fraud, where telehealth has been sort of involved in that, but they haven't really actually found any telehealth fraud where a telehealth provider has submitted a claim that said, like, I did this via telehealth. They found things around it, more around telemarketing fraud rather than telehealth fraud. However, that was sort of like the early days of the pandemic, or like information pre-COVID-19. So they have been looking at what's been going on during COVID. Nothing specific has come out yet, but again, they were saying that they were looking into it, but so far they haven't found anything, at least specifically towards telehealth, that shows that there's been more fraud in it than what they've seen in like other parts of the Medicare program. They do have 2 reports that are coming out. It's a little cut off here on the slide, but that second report, I believe, is out already. It came out a couple of weeks ago in March. It's the use of Medicare telehealth services during COVID-19. They haven't, as far as I'm aware, not come out yet with the program integrity risk. I don't believe that one is quite out yet, but just things to be aware of. It's like that fraud question still lingers out there, and definitely OIG has a specific interest in it. Next slide. A couple other federal actions to be aware of. There is the No Surprises Act, which does not specifically say anything about telehealth, but could have impact on telehealth delivered services. There are certain notifications or balance billing prohibitions that might impact like the way you have your telehealth program set up. There's also proposed regulations for 2023 health plans in the Affordable Care Act. They would need to submit information on services being offered via telehealth. And then also an interesting sort of executive order that came out at the end of last year regarding HIPAA, where the president had said that he wanted the Secretary of Health and Human Services to develop guidelines for entities around the use of telehealth underneath HIPAA. I have not seen anything come out with that yet. That came out at the end of last year. I don't believe there was a specific deadline to it, but that will be interesting to see what comes out of that, if anything, this year. Maybe like next year that we actually see something. Next slide, please. A couple other things to be aware of. So everything that I talked about here when I was talking about the physician fee services, those are changes to the permanent telehealth policies underneath the Medicare program. We are still underneath the public health emergency. So technically those policies have not kicked into place yet. So you do not need to like have a in-person visit with the patient before you do telehealth or audio only for delivery of mental health services underneath Medicare program. It's because we're in the public health emergency. So those public health emergency waivers for telehealth are still in place. Public health emergency was extended for another 90 days just last week. So we know like we have like problems that works out to, I believe, like around sometime in mid-July until then, where these policies are still in place. We may have a little bit longer because there was a reassurance by the federal government to the states saying that we're going to give you 60 days notice before we end the federal public health emergency. I'm not quite sure that means like 60 days on top of like a 90 days for an extension, or if they say like 30 days into like our current extension, we're giving you 60 days notice here. And then that still takes out to mid-July. But we know for sure that at least we have these telehealth temporary waivers sticking around until mid-July because of the public health emergency. However, for the 2022 budget, there was language put in there in the budget that said for some of the telehealth PHE waivers, we're going to allow them to stick around for another 151 days once the public health emergency is declared over. These were not all of the waivers. They only mentioned a couple of them. And they were basically to allow certain providers such as FQHCs, RHCs, OTs, and PTs to continue to provide services in Medicare via telehealth. So they're still good for that 151-day period. Those weren't all the providers who are allowed to do that during the public health emergency. Medicare had said, basically, if you're like a Medicare eligible provider and you're providing one of these services on like the temporary telehealth list, you can do that and we'll pay you. They did not do this in this language. They just limited it to a pool of certain providers who will be able to do that. And it's only for 151 days. They also did not include some of the other waivers that they did during the public health emergency, such as like the HIPAA waivers or the HIPAA sort of relaxation as well. The prescribing and controlled substances, that's its own sort of like policy category. That was also not on the extension for 151 days. So while there is an extension of 151 days, it is not on every single federal telehealth waiver. It is only on a few things. So keep that in mind. What they also did in this language was all those things that I said earlier about needing the in-person visit for the mental health visit and all that, that's also been delayed for this 151-day period. So there's a pause on that as well if the public health emergency is declared over for 151 days. I don't have any insider track information, but if you were to ask me, I kind of think like probably the public health emergency would be declared over after this 90 days that we have now is up, and then we're going to go into a 151-day period. That kind of takes us basically to the end of the year for these waivers and relaxations. It just seemed a little bit too neat for me to not think that. I don't know though. I think if there's like a huge surge again at some point, we probably will see another public health emergency. This is just sort of my guess as to what might be going on over the next couple of months. Next slide. So we're going to move over to the states. And now very briefly, like these are permanent Medicaid fee-for-service policies related to telehealth. And basically you have every state in the District of Columbia at least reimbursing for some live video. What's been interesting is we've seen like increases in store and forward and remote patient monitoring, but you can see like it's not as widespread as like live video and what state Medicaid programs do. The most interesting thing is audio only. So prior to COVID-19, there was probably only a handful of states that did any type of audio only reimbursement. And it's usually, the policy was sort of basically said that if live video doesn't work, you can switch to audio only as a backup. There was like 1 or 2 states that said that. And then a couple other states that said there was some case management that you can do via audio only, but it was very limited. And also a lot of states really explicitly excluded audio only from underneath their definition of telehealth. But now we're seeing, as of at least fall of last year, when we did sort of our last sweep, nearly half the states have some sort of audio only reimbursement policy underneath their fee-for-service program now, with that they've linked somehow to like Medicaid or to telehealth in some way. So that has been a significant change that we've seen on the state level and around their policies. Next slide. We're also seeing like changes on the commercial payer side. We're seeing more states either tinkering, because a lot of states already have telehealth private payer laws in place, but a lot of states are sort of tinkering with them in some ways to either like maybe expand the definition to include audio only, but a lot more states are being very explicit about saying like, you have to pay the same amount that you would have had the service been provided in person. Before the pandemic, there were only a handful of states that said that very explicitly. So you had commercial plans able to like not maybe pay the same amount as they would have in person, but now you have more states being very explicit about that as well. And you also have them coming out with like language too now of saying, well, you can't explicitly saying you can't have the patient forced into telehealth as sort of the first choice. They need to be given the choice of in-person or telehealth. Things like that, we're starting to see a little bit more come out, these specificities of what needs to be done, which in the past have been either pretty broad or vaguely mentioned or not mentioned at all. Next slide. So what we're seeing going on, at least legislative wise. So back in 2021, there were 47 states that passed over 200 bills related to telehealth. Again, a lot of them were what I mentioned earlier around private payer reimbursement, Medicaid reimbursement, and cross-state licensing. So we haven't really talked much about licensing, but that's definitely been like a big policy issue that's been discussed both on the federal and the state level. And some states have been addressing that. They've either been joining compacts, or interestingly, 2 states, Florida and Arizona, created registries where thought is if you get on that registry, you can provide services via telehealth and you don't need to be licensed in that state. So we're starting to see like different approaches on addressing this licensure issue. We're also seeing like policies that are impacting specific professions, such as like requiring boards to maybe come out with like, specific guidelines or how you deal with like prescribing. So we're seeing more of that as well too. Next slide. What can we look forward to in 2022? So some of the trends that we're seeing now is like states are still struggling like the feds of like, what do we do post PHE? So like trying to figure out what the permanent policies are. Again, the big things are like Medicaid and private payer changes. That's always going to be a big thing because that's your biggest swatch of telehealth policy is what's covered and what's reimbursed. And then explicit direction, like again, more specifics on what they're supposed to do once they do telehealth, like what documentation do you need, what record keeping do you need? And then we are also still seeing telehealth standards for various professions. So we're seeing a lot of like what we saw in 2021 continue on in 2022. And I think that may be it for the slides here. Yes, and this is our website that you can go to if you're interested in a specific state. We also have a newsletter that, the link I think is cut off again. When you get the PDF, you should have like all these links. So apologies for that. But then that's about it. And I'm happy to take questions if anybody has any.
Thank you so much, May. Yes, we would love to take your questions now. You have a couple of options. You can unmute yourself and ask your question, or you can open the chat box and type it into the chat. When you open the chat box, I think it defaults to everyone, so everyone sees your message. If you would like to select my name, Cassidy Avila, from the drop-down list, you can send your question to me and I will ask it on your behalf if you prefer that. So we'll give you guys a couple of minutes, and I'm sorry, I opened the slides, and I guess maybe just coming from your computer to mine, they kind of got all crazy. But we will definitely make sure that you have all the links and all the information properly formatted when we share those with you.
I think that's my fault. So I work on a Mac. So I notice that happens when I send
Oh, yeah.
yeah, it just sort of messes up the formatting, but the PDF should be fine.
Yeah, absolutely. And we'll make sure they see the link to the newsletter and all of that good stuff too. Let's see. I don't see anything yet, except there was a question about CEUs, and no, we do not have CEUs for the presentation today. But thank you for checking. Okay, I don't see anything yet. I did just drop the 60-second survey link into the chat. It's truly just a couple of questions about the webinar today and any topic you might like to see in the future. Let's see.
There was a question about the link for the category 3 list of covered services. If you go to, I don't have the direct link, but it's really easy to find. If you just Google CMS telehealth services, there should be, it should pop up like a link to the CMS website, and there's an Excel spreadsheet on there. And basically the Excel spreadsheet tells you sort of like what are the codes that are PHE, what are allowed by audit only, and what's in category 3 as well too.
Great, thank you. And then Oh, you know what? This survey link didn't go through. Okay, thank you for letting me know. I actually sent that privately when I was demonstrating, I guess, to myself about selecting someone's name in chat. Give me 1 second, and there, you should see the survey link now. My apologies. And so if I back up just a little bit, so someone was asking about getting the slides in the recording. Yes, so within about 24 to 48 hours, you will get an email from the Center for Optimizing Rural Health. And in that email, there will be a link to our webinars page, and there you will see the recording for today, as well as a link to download a PDF version of the slides. So be looking for that in your inbox. And yes, we would love for you to share it with your team.
Mhm. And I apologize also. I know that Medicare stuff is very confusing on like, what's allowed for mental health services, how can you do a mental health services, and does it go into effect? And it's like, no, because we're in the PHE. It is very complicated. We do have some resources on the CCHP website that kind of walks you through that a little bit, like at least on paper. So that might be easier for some people to have that resource as well too. So you can just go to the CCHP website and look under fact sheets, I believe is where it is.
Perfect.
You do kind of need a little sort of chart to try to work through. It's like, wait, what did they say? And I didn't even get into, they made exceptions too, but it's like kind of confusing as to what those exceptions are.
It's so much information.
Mm-hmm. Yeah, it's just very detailed. There's a lot of details for each sort of thing, that each policy that they put into place. It's like, yes, but not if B, and only when C occurs or something like that.
Okay, I don't see anything in the chat. So I think we'll go ahead and give you about 10 minutes back. But if you do have a question, please feel free to reach out to us. You can reach out to CORE, you can reach out to CCHP to get your questions answered. We will be more than happy to support you. So I just want to thank you all again for being here with us today. And thank you so much, May. It was an excellent presentation, and we're so grateful to you. And I wish everyone a great afternoon.
All right. Have a great day, everyone. Stay safe.
Bye, everyone. See you
Bye.
next month.